So thank you everyone that's been able to join us so far. We're excited to have you join us on this timely discussion on the evolving landscape of Medicare Advantage. So as the healthcare industry braces for all these potential shifts in policy and regulation, one question remains on top of mind: how can AI help organizations, healthcare organizations specifically, navigate the inevitable changes while maintaining financial stability and delivering high quality care? So I'm pleased to have with us two of our esteemed guests, Dr. David Nash, MD, and Dr. Arun Hampapur, PhD. And Arun is our expert here with AI, and Dr. David Nash is very versed as far as regulation goes and in healthcare and just the healthcare landscape overall. So we have this webinar sponsored by Bloom Value, which is an AI-driven enterprise platform which empowers healthcare organizations, hospitals, health systems, Medicare Advantage plans, and risk-bearing entities in general to unlock deep insights, reduce costs, and drive revenue. So by blending cutting-edge machine learning with decades of healthcare expertise, they help organizations not just change, but thrive in all the changes that are coming our way. So we'd like to get started, but just as a quick note, we would like to offer to all of the participants the opportunity to ask any questions they may have. Please put your questions in the chat. And as we go through the webinar, I'll be monitoring that and bringing up the questions as they become relevant. And so we would like to have that participation, and we'll try and leave some time at the end for some Q&A. So my name is Jared Turley. I've been in Medicare Advantage for over a decade. I'm currently the CFO of Novano and Promise Care in California. I've been doing this, like I said, for over a decade, and we have over 100,000 patients that we are dealing with as it regards to Medicare Advantage. And so we have had a lot of questions related to AI as it's become more relevant to healthcare in the past couple of months, which has prompted a lot of questions. And with Dr. David Nash, we have brought to the table one of the biggest questions in healthcare right now is there's new administration that's coming on, and AI, there's a lot of regulation potential in the future, and how all of these changes are going to be affecting healthcare are some big questions that a lot of people have. So I would love to open up this webinar by asking Dr. David Nash, what do you feel are the biggest challenges facing Medicare Advantage today?
Wow. So first of all, great to be together. Thanks, Jared. Thanks, Arun. Thanks, Bloom. And thanks, Aspire Partners. And most of all, thanks, Jefferson. Wow, where should we start?
Well, actually, Dr. David Nash, I don't want to cut you off, but please just do a quick introduction of yourself, and Arun, you as well. I don't want to skip over that, so please get your shot in and please introduce yourself.
So it's great to be together. I have been on the full-time faculty at Jefferson for 35 years. Jefferson, with my little pin here, has been around for 200 years. So I've been 18% of its total history. But seriously, I'm best known, I think, in this setting for having been the founding dean of America's first College of Population Health back in 2008. I was dean for 11 years. Now I'm back on the faculty full-time in my capacity as a professor of health policy. So that's my connection to this opportunity today.
Wonderful, wonderful. And Arun, just do a quick introduction for yourself. And I apologize for not getting those in earlier, but please, we'll dive right in after your introduction.
I have to lose to David, who has the winning Eagles thing going for.
Thanks for saying that. Yep. Our parade is Friday, so EAGLES.
I only work for an organization that's 120 years old, which is IBM, prior to Bloom. So it can't compete with the 200 of Jefferson, but we absolutely, it's a pleasure to be here. And the short version is I started Bloom about 4 years back, right in the middle of the pandemic, as part of the Great Resignation. Asked the question, am I doing the right thing? And that's how Bloom came about, along with my co-founders. Prior to that, I was with IBM's research division, worked on various incarnations of AI. It used to be called cognitive computing before. Before that, it was called data science. Before that, it was called big data. Before that, it was called analytics, and so on and so forth. But I started my journey at the University of Michigan from the AI lab. So we were actually trying to make cars and golf carts drive around the campus of the University of Michigan with cameras and computers bolted onto them. So it's really fascinating to see that has already finished 2 million rides or something like that, self-driving cars. It's a fascinating time to be around. Thank you so much for having us.
Okay, so back to the question. What are the biggest challenges facing Medicare Advantage?
Yeah, so great question. And my short answer is, where should we start? So look, personally, I get it. I'm a strong supporter of Medicare Advantage. Makes sense. I had the privilege of being on the board of directors of Humana for 10 years, so I certainly appreciate the market position of Humana, United, Centene, all the others. But I think the biggest challenge right now, Jared, is twofold. Medicare Advantage has lost its true north. I mean, it's all about improving health. But sadly, because of pressures from Wall Street and elsewhere, and hitting that every quarter stock price, it's been more, sadly, about upcoding and enrollment and a competitive race of who could offer the most benefits that aren't directly connected to health. So my short answer is the biggest challenge is Medicare has lost its true north. Its true north was to improve health, to buy coordinating care, practicing based on the best available evidence, helping people with chronic illness, doing things that traditional Medicare couldn't do. And if you look nationally, about half of all Medicare beneficiaries are in Medicare Advantage. So it's here to stay. Excuse me, but I think its number one challenge, and we could get into the details, is it's lost its true north, which is sad. And if you look at Wall Street's view of Medicare Advantage right now, for better or for worse, the stock market agrees that the fundamentals are not good, and everybody in the entire sector, in the for-profit MA sector, everybody's stock price is down, and every provider organization that owns an MA plan is rethinking and trying to figure out what's wrong. But we'll come back to it. But the short answer to your great question is they have lost their true north, in my view.
Yeah, and it's interesting because Medicare Advantage should be managed care, and you're right. There's a lot of issues that have come up recently in the last few years. And from my side as an operator, we have seen a lot of increase in spending on medical claims. So
Yes.
What factors do you think in your mind are driving those increased medical spends by these Medicare Advantage plans?
Yeah, so great. And again, this is shouldn't be the core conversation, but it is. And those drivers are a couple of things. Baby boomers like me, 1955, the zenith year of the baby boom generation, right? 10 years after the end of World War II, everybody's having babies. And the 1955 babies are the zenith year, crushing overutilization, hips, knees, GLP, you name it. We want it, and we want it today. So I'm not an actuary, but no one should be surprised that post-COVID utilization, was asymptotic to the ceiling. So that's one part of the driver. Second is, as I alluded to before, market competition. These for-profit plans were tripping over each other to offer benefits within Part C Medicare Advantage that seem to me not directly connected to improving health. Sure, giving people spinning classes and helping to defray the cost of certain food for certain MA members is a good idea. But the main challenge is these benefits are not connected necessarily to proven clinical outcomes. So there's been lack of clarity, lack of transparency that when we offer these benefits within these various MA structures, that they're connected to a better clinical outcome. So overutilization and competition on benefits.
If I may jump in here on your
Please.
point on offering benefits, this is one of the places where technology, AI can help. As you pointed out, if you give everybody spinning classes, maybe half of them are not going to use it, and we just a whole bunch of money. But you can actually use data to say, well, who are the ones who are likely to take up that benefit and where that's going to impact health outcome. So to be able to segment that population and target these additional benefits to the specific types of people is entirely within the realm of possibility with data and AI. So I'd say that's possibly a way to address the challenge, both on the cost side and on the benefit side. Like if you can.
Sure. And we could say the same, Arun, for the social determinants of care. And look, we know that MA members, as compared to traditional Medicare, on average come from a lower socioeconomic area. So better AI-enabled risk stratification would go a long way to figuring out what services do these people really need. Maybe what they really need is a van to pick them up and take them to a senior center because they're all alone all day long, and it's leading to dementia and increased costs and all the rest. And maybe what they really need is to have that shag rug taken out of their bathroom so they don't fall and break a hip and then cost everybody a fortune and end up in the hospital, et cetera. So, look, again, we could do a much better job. I think, sadly, Jared, most observers would agree that for certain plans, there's been also, some pernicious stuff. Let's be real. There's upcoding. There's nurse visits to figure out which diagnoses we should add to each person. And then we don't tackle those diagnoses. We don't shoot for a better, improved clinical outcome. I think the fairest way to look at this is there's plenty of blame to go around. I get it. But if you ask me, the biggest problem, no true north, overutilization, lack of an evidentiary basis, and then nonsense on this side. Upcoding, inappropriate visiting. I mean, we could go on. And it's sad because, again, I'm a great believer that if there really were a link between the process measures and the outcome measures, and we really had risk within MA, and a lot of experts, not me, but other very super smart people believe that of all the 35 million people in MA, 10% are really in a true risk-based environment. It's some people believe it's a fee for service in wolf's clothing, meaning it really isn't focused on care coordination the way it should be, on outcome measurement the way it should be. And we could get into it. It has a lot to do with star measures and all the other crazy, unique stuff to Medicare. So lots of issues at the ground level.
Yeah, and then throw on top of that, we have a V24, V28 ICD-10 change that's coming along.
Yes.
And,
so once again, if you look at what V24, V28 did, and for some of the folks who don't know the jargon, these are what you could call stroke of a pen risks that every MA plan has, and meaning CMS decides certain codes are no longer applicable. Well, hair on fire, pulled at viral harm, let's figure that out. Let's go get in. We'll need the AI to help us now to predict, well, how are these coding changes going to affect payment? What we're not asking is, how do these coding changes affect clinical outcome? That's really my central point. And you can't blame the plans to try to, when you pull the fire alarm, the fire trucks are going to arrive and they're going to try to put out the fire. understandably. The broader question is, why'd the damn fire start in the first place? And that's the analogy I'm trying to make. And if we had a true north, we wouldn't be quibbling about V24, V28. None of that nonsense would be happening out of CMS. They would say, what are the really important measures within STARS that drive improvement in health? I think we need to reset the conversation. And, that's Nash's view, easy to say, hard to implement. But we got to get back to the true north. We're here to improve health. If that's the case, as a professor, I'd give the industry a barely passing grade, and I'm an easy grader.
Good to know. If we're ever in your classes, we will hold you to that.
The older I get,
I appreciate you bringing up. Right. I do appreciate you bringing up the AI aspect of how that visibility can come. And Arun, what has been your experience when it comes to AI with problems like V24 and V28 upgrades? Changes.
So there's what the tool can do, and then there's how you apply it. Two different bits of it. So as far as the machine is concerned, we have models. We have what we call transcoders, transition impact projection, you name it. And that's table stakes. We can take a population of 10,000 people in any plan or in any group and run them through the V24, run them through the V28, look at the difference in RAFs, look at potentially aligned ICD codes that the physician should be considering, where have they used unspecified and where should it get a little more specific in terms of the diagnosis, so on and so forth. But the interesting part, I'm actually at a risk adjustment conference today, Jared, in Dallas, and the first discussion was on this topic. And the question is, well, how do you convey the importance of this whole coding thing to the physician? Because the physician is really interested in the outcome. So the point they were making is physicians are physicians, coders are coders. The twain shall never meet. There's nobody who really knows both of it together. And hence, we have this somewhat of a gap. It was a very interesting point. Yes, AI can provide the data, but you need to wrap a process around it. So let's take a patient and let's say their RAF is going to drop because of the transition. But what are we going to tell the physician and the set of providers, and how do you guide them in this process without necessarily turning it into an upcoding exercise? Not a very easy thing to do. That's really where the rubber meets the road, if you will.
Well, so Jared, what a great answer from Arun, and my condolences on being at a conference based on this topic. God. But seriously, look, doctors don't care about coding. I mean, I'm a primary care internist. I was in practice at Jefferson for 30 years. I'm a terrible coder. That's not what we're trained to do. And if we really were at economic risk for clinical decision-making, that's at the heart of what MA was supposed to deliver. So we would be focused on care coordination, the right resources to the right patient at the right time. If that were the true north, then the coding would, if you would, take care of itself. We would be doing the right thing at the right time. Since it really still looks a lot like private practice fee-for-service, even within MA, then coding takes on a disproportionately important role. I get it. And as I said before, there's plenty of blame to go around. I understand. But, focusing on teaching doctors to be better coders or hiring an army of coders, let's figure out, since MA is, roughly $50 billion more expensive than regular Medicare, let's take that $50 billion and put it into care coordination, better AI tools. I would ask the question, instead of, here, David, here's your list of patients for today in the MA plan. I would ask the question, hey, who's not here today that we really need to see them? Now, let's use our AI tools to figure that out. So, Mrs. Jones, her creatinine went from 2 to 4. Do you even know about this? She had an ER visit for renal failure. Oh, wow. Well, she's not here today, so let's get the van to go pick her up and bring her into the office. Now that is care coordination, focusing on the true north, improving health. Hey, did you know that, Mrs. Smith lives in the 5th floor of a building and there's no elevator and she can't get to the appointment? That's why you haven't seen her. That's why she hasn't shown up for her annual wellness visit. Well, let's go scoop her up and bring her in. And while we have her in the office, let's talk about what the impact of those social determinants are on her health. So this is how this all should work. Instead, V28, V24, pull the fire alarm. Oh my goodness, let's fix the coding. That is not the answer.
Yeah, and I really like the answer that you gave, Dr. Nash, because there are so many opportunities for AI to have some of these improvements. Absolutely. And healthcare has been such a slow adopter of technology, just period, over decades and decades. But I can feel that there's some changes shifting in healthcare, specifically related to AI. And one of the negatives has been in the news over this overuse of denials by United Healthcare. And I was curious, Dr. Nash, what your perspective is on the cost containment activity by these Medicare Advantage plans.
Well, I think we're just going to generalize, and we should just take a moment to think about Brian Thompson and what that means for the industry. And I did not know Brian, but I know many people who thought the world of him. And then to see online that people justified his cold-blooded murder and daylight in New York City. I mean, horrible, but it's a symbol. It's emblematic of the anger that people have. And I think let's dissect it. Again, my view is there's plenty of blame to go around here. Part one, I don't think these companies have done a good job in explaining what they're all about. They're here to improve health. So let me show you the 10 ways we're going to improve your health. So very unclear messaging. Second, prior authorization. Well, here's where AI would be so much more powerful and valuable than the millions, tens of millions we waste in going through this ridiculous process of having to call and beg and approve the test. And I don't think there's a family member in America who has not experienced this crazy process of prior authorization. So last comment on prior auth is, look, if we had solid evidence to support what we do every day, you wouldn't need prior authorization. And let me remind everybody, of course, all the clinicians in this wonderful conference know that 18% of what we do every day is based on grade A evidence. I'll say it again. 18%, roughly 1 out of 5 decisions at the bedside has a randomized controlled trial evidence behind it. The rest, 80%, is the art of medicine. I get it. And that's where the kerfuffle is. Well, your art, I don't appreciate your art. I like modern art. I don't like Baroque art, to make the analogy. So AI could help sort that nonsense out. I'd like to see a world with no prior auth, because we're just practicing based on the best available evidence as partially determined by new tools.
So Arun, sorry, go ahead and comment.
We're in fact on our way to doing that at Bloom, and there are several other companies that are trying to do that.
Great.
There are two dimensions to this. I'll go back to the claims denial topic that Jared teed up. That's somewhat crying over spilt milk,
Right.
To try and deny a claim after treatment's been done means that you didn't really think about all of the care coordination that needs to happen before the patient went into the surgery or got the treatment that they were supposed to do. And that absolutely leads to the prior auth question. And David, we've been looking at that. Me not being a clinician, I look at everything really as a systems problem, right? You think about what is the system, and why do we even have prior authorization is a question. And part of it is a lack of trust that the payer has on the physician, right? I mean, if you trust the physician, then hey, he's the guy who knows the patient. He should basically be given the right to do any treatment that's necessary.
Yeah. Well, let me jump in there, and this is not a new topic for me, and there are lots of wonderful people listening in today, and you can't see because I'm sitting down. But Arun, you got to be careful here. When I got to Jefferson in 1990, I was 6 feet 2.5 inches tall. Right now, I'm 5'6". So it's not true that every doctor and nurse is doing the evidence-based best available practice. I mean, it's simply not the case. So what we need is immediate closure of the feedback loop to help us make the right decision. Unexplained clinical variation is the Achilles heel of the system and has been for 35 years. That is the core problem. And we're using these tools like prior auth to try to put guardrails on unexplained clinical variation. So what I'm hoping is that AI eventually will crack the unexplained clinical variation dilemma and give us immediate feedback. Some of these tools already exist. Hey, David, you've ordered the wrong antibiotic. What's up with that? Or let's automatically review every single inpatient chart at Jefferson at our Center City Hospital, and we're going to look carefully, automatically, maybe who has sepsis and who doesn't, because individual doctors, nurses, pharmacists can't possibly make the right decision every day, every time. So it's a two-edged sword. There's a lot of unnecessary utilization out there. That's why we have prior auth. I get it. But I'm hoping for a day, and I hope I'll still be around to see it, where it's based on the best available evidence. Instead of 18% of the time, it's 60%, 70% of the time we have good information to make the right decision. And it's where that art of medicine comes in, that we have legitimate differences in opinion, but don't blame it all on the tool. There's a lot of bad behavior out there on the part of people with, writing the orders.
Indeed, it's in my mind, it's a two-step journey. One is there is an existing process, and there's a lot we can do to make that existing process better with automation and intelligence.
Indeed.
So I read this statistic somewhere, David, you can correct me if I'm wrong here, that it takes an average of 14 days in the US to get a prior auth approved.
I mean, everybody on this webinar has a personal experience. Yeah, I mean, I'm happy to share, of course, in our family, no difference. I mean, it's crazy. And again, what's the true north? What are we here to do? We're here to improve health. Okay, given that, and that's where we're going to get return for shareholders by improving health, improving patient satisfaction. I think, Jared, going back half an hour ago, part of the dilemma here is, what do we mean by value, right? Medicare Advantage is supposed to be value-based care. That's the whole premise. So I would argue that term is really complicated because it depends on your perspective. Value to a shareholder would be, get this sector out of the basement, okay? Value to me as a MA beneficiary might be, hey, I'm lonely. Hey, I'm hungry. Hey, I'm in chronic pain. I need these issues addressed. Well, that's a pretty complicated. Or, hey, my blood pressure's out of control. And I could think of 100 other clinical and socially determined issues where there's the star measures don't really capture what I just described. So, we need an overhaul of our thinking, and maybe we could get into what the new administration is going to try to do here. But if we had AI tools that could say, Nash needs help in transportation, which is why he can't get to the office and which is why he hasn't had his annual wellness visit, now we're talking about getting in the right direction.
Yeah. And David, if I may, just one topic thought on that. Just as a practitioner of AI, it's entirely feasible to build the tool, right? And
Yeah.
several people have variant of it. What I find typically is the gap is, okay, what next? Like if we give that tool to Jared, saying, okay, we can tell him which patients need the right to come in. What process goes around it? What business
That's
model
right.
goes around it? What liability is there? Should we send our van out? So on and so forth. So Jared, how do you think about using such AI in your practice or in your operation as a Medicare Advantage operator? I'd be curious to hear your thoughts.
Yeah, so there's kind of like a pre and post thought with AI being implemented because pre AI we were in sort of a dark operations mode where we were trying to look at all of the prior authorizations and get them before 14 days because as the operator we want to make sure, is this medically necessary, and go through all of the 14 different steps it takes to get that prior authorization approved. But then there's, all these other dark operations with utilization management, trying to make sure, okay, well, we have 2 urologists, one costs less. Can we make sure that the patients, as long as the quality is the same, get to the one that costs less? And there's a lot of opportunity for AI. And so post AI, there's a lot of opportunity in that, not just coding, which is important for the operations standpoint, but also making sure the authorizations are, if you have like a standard number or a standard process for getting an authorization out and you're going to approve it anyways, it's just a timing. Just let the AI process through it, get the authorization out so that the care can be done quickly. I think there's so much opportunity.
A great question, Arun, and pretty good answer, Jared. But let me focus. You're the operator. We're just the talkers. But let's focus on your great answer, because buried there is like 20 other topics. Okay, so you mentioned a specialty and you want to go to the cheaper one. Sure, makes sense. What's missing is, did that specialist deliver value, a good outcome at a competitive price? And I would argue that you have zero information on how to establish that. So let's go back to the topic at hand. MA was supposed to be a narrower network. I prefer the term value-based network, where the thought would be, you specialist, urology, cardiology, you're in my network because we have data that shows, using new AI tools, that when I send a patient to you, we're going to get a good outcome, you're a good communicator, high patient satisfaction at a competitive price. I would say today you have zero idea who they are, how you get that data, and it's all price-based. And
I would say that
that's
using AI,
important.
we are getting much better.
Right.
But there is so much opportunity, and you're right.
That's why we're here with Bloom talking about this. And
That's right.
to Bloom's credit and to the credit of other big companies trying to figure this out, if everyone is in a network, there's no network. This is it's axiomatic. It's self-evident. Having a network has to have teeth. And then the question becomes, well, how do you get in that network and how do you stay in it? And what are the measures? And the current STAR measures don't really have the ground level data that we need to make those attributions. That's another weakness moving forward that MA needs to fix. Great idea at the outset, a value-based network or narrow network, if you like, makes sense. Now, how you operationalize that, this is where AI is going to really, really help. Because I'd like to know that cardiologists, their utilization data, cath data, stent data. Look, we have good information that even when you send, this again, ambulatory congestive heart failure, the care of patients with heart failure, we have solid evidence that you might as well roll the dice, even when you're seeing a cardiologist, that you're going to get the correct outpatient meds to treat your heart failure. If we had AI tools, we would do much better here. So, okay, bring it on. I hope I live to see it. It's very, very exciting. That unexpected variation is the source of the waste, the source of the challenge, and why we need the AI tools.
And we're ready for it. Now, before we go down we can go on this topic for days on just all of the different facets, but we do need to continue on to one of the main topics we wanted to bring up, and that is the latest policy changes and their impact on Medicare Advantage, because there's just so much going on right now. But Dr. Nash, we wanted to bring this up with you specifically as an expert on what are the areas in Medicare Advantage that you foresee being changed by the new administration?
Yeah, that's a great question. And, I don't have any secret inside information to share. Everybody reads the same stuff I read. I mean, great that Mehmet Oz is a doctor. I've had the privilege of spending time with Dr. Oz in various settings. He's controversial, no question. There's lots of strong feelings about him on the left and on the right. I hope that he will think about the true north for Medicare Advantage. And we all know that, Dr. Oz isn't going to do all the daily work. All of his chief of staff, Stephanie Carlton, people like Christopher Klump, Abe Sutton, these are brand new names to me, all of whom have been, potentially put forward as key leaders. They have a history of coming from the private sector, of understanding big data, most especially Chris Klump, of having entrepreneurial views. So maybe they're going to inject, I hope, a sense of efficiency here. I know that CMS is also talking to DOGE, the Department of Government Efficiency, about reducing fraud and waste. Okay, maybe something positive could come from that. I'm trying to be hopeful here. Let's put it this way. Current spending levels are not sustainable. This is, whatever you're a Dem or a Republican, current spending levels are not sustainable. Okay, then let's find new ways, keeping the true north in mind, of tackling this issue. So my summary about the new administration is, so first of all, I want to wish them good luck. It's in the national interest to fix this mess. If I were part of the team, I would tackle fraud, but I would go to star ratings as my first thing, take that thing apart and put it back together, and use measures that are connected to outcomes, clinical outcomes, and value to the individual patients, and make it much less complicated.
And Jared, the new administration's policy is not just on the health side, but as you might have heard, when David said star, it triggered Stargate in my mind.
Oh boy, right? Yeah. I'm talking about star ratings, not Stargate. I'll let Aaron talk about Stargate, right? And who's going to own Stargate at this point? This is a big problem as of today's news, right? I mean, crazy.
Indeed.
Against Musk, who's going to own Stargate? I mean, sounds like something of science fiction.
But David, I kind of look at that. I step back, and the way I look at that announcement is, if you look back at the last, 10 presidents of our country and talk about which one of them within the first week brought technology up at such a high level in the forefront, to me, I look at it from that perspective and say, well, there's many more questions for us to answer on exactly how that whole project plays out. But the fact that the president and three of the most famous entrepreneurs in the business stood up and said, hey, we've got to do this.
Great.
And then what happens next week with DeepSeek and all of the tumult that market. But it's an indicator that we have to talk about technology and its application in the same breath, right? It signifies to me, and I was super excited to hear the announcement. Data centers are absolutely necessary for this technology, and the way it gets implemented will evolve. But it's clear that leadership is thinking about both technology and policy and healthcare all in the same breath.
Well, to that point, Jared, let's get back to, you raised the issue of which specialist is in the network. And wouldn't it be amazing to be able to get that level of transparency down to the individual orthopedist, cardiologist. How do I know where to send a patient for a total knee or to get a cardiac cath or to get a colonoscopy? I mean, if we had that level of data, which I believe is obtainable in the near term using these tools, I think that would go a long way to improving care coordination, improving outcomes, reducing waste, reducing unexplained variation. I mean, it's super exciting given what the possibilities are. And like in lots of things, the technology will diffuse into practice before we have rules to, contain it. And how we create those rules will be very, very important. I mean, it's amazing. Already the AI implications in clinical practice, most especially in pathology, radiology, laboratory medicine, are changing the very nature of how we review slides, how we review films, all of that. And we can bring that super level of expertise to everybody. I think that's fantastic. So, is the genie out of the bottle? So it depends on your perspective. But if we think about value to the patient, that's got to be part of the true north. It's really important.
Yeah, and as we were preparing for this webinar, Jeff from Aspire Partners sent us the post from Tom Lowry, who is an AI thought leader, about the mixture that we have right now, or the balance that we're trying to find between gas and guardrails as it relates to AI. Right. We want a lot of these things implemented within healthcare, and we want it as fast as we can get it, but there need to be appropriate guardrails. And Arun, this is a question to you, because in speaking of guardrails, you can have data, because there have been studies that comes in that might not be appropriate to be ingested to have this AI model or machine learning be able to really contain some of these, either inappropriate demographics or inappropriate outcomes, inappropriate spending. There's a lot of opportunity to have that get into the machine learning. So how are you setting up those guardrails within Bloom Value?
So I take the approach of when you think about AI, it's a tool. And the way I see it, especially in some of these decision-making processes, is it's a question of needles and the haystack. Right? We're never going to, in the foreseeable future, there's always an expert or a human in the loop when we're trying to do prior auth adjudication or claims, whatever it may be. The question is, out of 1,000 claims or 1,000 prior auths that are on the table, how many should be sent to the expert and which ones? Because, Jared, as you were pointing out, the way we think about AI is if I can pick out the 800 or the 1,000 prior auths that absolutely can be approved instantaneously because they're within the financial guardrails, the clinical guardrails, you can apply AI in that way, which basically says it's going to accelerate the process. It will only approve. Wherever the machine has a doubt or it needs more help, we just send that to the expert with the right information. So any decision that's going to potentially negatively impact the patient or the provider actually has a human, and they bring into the decision making a lot of other context that's absolutely necessary. So this is one way to guardrail the use of data, right? Sometimes when you take data and let it make the decision, then it's somewhat doesn't have all of that human context. So we basically say, well, if the decision is going to positively impact the patient, then let the machine make it. If it's going to potentially negatively impact the patient or the provider, let this bring the expert into the loop. And now they can just focus on the 200 needles and not worry about the 800 bits of hay, which obviously they were going to say yes to.
Yeah, and there's a lot of hay when it comes to operations within any healthcare organization, and it can be frustrating. Now, we've talked about risk adjustment. We've touched on 5-star and utilization management. Where do you see, Arun, AI helping with and cost management?
So, Jared, as I've learned about healthcare and learned about managed care, and more specifically Medicare Advantage, I've come to the conclusion that the best way to think about AI is from an enterprise perspective. Yes, there's risk adjustment. Yes, there's 5-star. Then there's prior auth. There's claims. There's visibility. There's so many different aspects where we can bring this kind of technology. So what we've thought through is, what's the enterprise platform for bringing AI to Medicare Advantage? What are the different components of that enterprise platform? And as we've looked at it that way, what we find is, hey, absolutely, almost anything that Jared, you do, I'm hoping that I can help you do it better with either a dashboard or a recommendation engine or an automation, or you name it, right? So, but we should think of it holistically. To David's point, what he's been saying is, look, all of these are really about providing better care and getting to the true north. And you can only get to the true north if you're really driving the bus on all its wheels. If you're fully tilted towards risk adjustment or only towards authorizations or claims, if you AI one piece of the puzzle and don't apply AI somewhat uniformly, you're going to get a very imbalanced answer. You may be getting your margins may be going up because you're denying a lot of stuff, but your quality could be tanking. So you really need to bring the technology across the enterprise. And in my mind, that is the holy grail, right? So if you think about enterprise AI, and David, I'd like to tie that back to value for whom in a minute.
Right.
Back to Jared here.
Yep.
Yeah, it's super interesting to think about from an operations perspective, because we have so many different silos depending on your organization and size. But QM, cost optimization, revenue eligibility, and there's almost every single one of those have their own, software or application behind it that's being used. And for an enterprise, so is the enterprise solution, it makes sense. But going back to this idea of care coordination that we've had brought up by Dr. Nash, I'm curious, Dr. Nash, to see how you see AI influencing the future of care coordination.
Yeah, great. Let's go back to one of the examples, make it a personal story. So my late mother was at one point a Humana patient, and the nurse visit to her home demonstrated that she didn't understand her medication. So she needed a special education that could all be AI enhanced and could have been delivered much more effectively. Also noted that she had the proverbial shag rug in the bathroom, so they had to figure out a better way. So, at least they were asking the right questions, all of which could be enhanced with various tools, remote patient monitoring. I wish that my brother and I had access to those kinds of tools when my mother was still alive, to see, was she taking the meds? Was she on the appropriate diet? Was she exercising? I think AI can link that Internet of Things, give us feedback. The future is amazing. So we could do a lot to improve care coordination, the grunt level work of, you're only in the doctor's office for 15 minutes if you're lucky on a, ad hoc basis. All the real work occurs outside of that. So that's where we need the tools to do the care coordination, the education, the medication, the reducing loneliness, the tackling the social determinants. That's where these tools are going to have the greatest benefit. In addition, I think, to what I'll call, the clinical decision support. Hey, this is the right drug for this patient, not what you picked. And we can do that today when we have the true north in sight, when we're really at risk economically for clinical decision making. And as I said at the outset, about 10% of the 37 million MA beneficiaries are really in a true risk-bearing situation.
Yeah, and that now brings up what Arun hinted at earlier, which is this idea of value-based care and value-based to whom. So I'm curious as to your perspective on value-based care and where is the true value being seen?
Well, for me, true value will be improving health. America is the unhealthiest developed country in the world. we're not in the top 10 of any measure of the health of the population compared to Western developed nations. So for our $4.5 trillion a year, we are not getting a great outcome. And so, I mean, that's the cornerstone problem.
Ash, typically what happens is that yes, there's value for the patient, but you know we are a capitalist society. There's always got to be value for the shareholder, and then there's the physician stakeholders in the process. What I've noticed when I look at these interests sometimes appear to pull in different directions, right? Like they appear to compete when you look at it at a very high level. But what I've observed, not just in healthcare, but in many other industries is, hey, if you can break it down, if you can get to that core risk stratification idea that you had, that those interests don't necessarily compete. They compete at a high level, but you know, shareholder value and patient value actually will line up for the right risk stratified segments. And that's really where I think we can bring technology to bear to truly transform the system, where we can address Dr. Nash's loneliness question in the context of a business model, because that is always going to be very, very important to do.
And that's part of care coordination too, Arun, as you know.
Right.
Yeah. Indeed.
Yeah. So Arun, there's a question
in the I just noticed just for your information.
Oh yeah, I was going to bring up that question because one of the questions that one of the attendees brought up was this idea of Medicare Advantage health plans weaponizing this AI to deny care. And from your AI perspective, Arun, what is the solution for this technology, either in being prevented or in using this in a productive way, to Dr. Nash's point, to actually provide a value-based care, a quality outcome for the patient?
That's a scary question. Weaponizing AI to deny care. Oh my God. Wow. Go for it, Arun. I'm listening.
So Dr. Nash and Jared, I'm simply going to say, well, AI is faultless.
Right.
It's the machine, right? You know,
it's blameless. Yeah, of course.
It's really how it's the standard argument we've had about guns in this country forever and ever. You know, it's like, yeah, you can use, the police officer can have one and use it for good, and a bad guy can have one and use it for bad. It completely is a policy thing. The machine, we can design it to say, okay, here are the ones that you should approve and here are the ones you should deny. Well, it's the organization which decides, well, what should I enable the machine to do? And this whole idea of guardrails is very much a policy question. It is not at all a technology question. It really is, how does the payer organization or the Medicare Advantage plan think about these things, and where do they want to apply these technologies? Very much a policy question. But I'll wrap by saying, you know, we can make the AI absolutely give you the best possible set of answers, but which ones do you automate? Which ones do you run through a human? Jared, I'm going to punt it back to you and say it's really your decision. You're the operator here.
Yeah, and it is, in using these tools, it's always been great to see that the tool is not making the decision. But even in the example of the prior authorizations, when we have a policy that the company has set, or in our case, an IPA, we have set the threshold for where we prior approve or automatically approve. And that's, when I say automatically, that's still an operator or a human being clicking the button to approve authorizations, but we've set the standard. And anything that needs to be reviewed is either set by a dollar threshold or by a procedure threshold, or whatever the standard may be. It is set by an individual. And Dr. Nash, any comment on that?
Yeah, well, you know, culture eats technology for breakfast. So here's the dilemma. You know, your plan has your set point, and my plan has a different set point, and Arun's plan has a third set point. And this is what drives patients crazy. And you have a different formulary than I do, and on we go. So until we have a more solid evidentiary basis for what we're doing every day in the office and at the bedside, then we could make sense out of this. And now let's just add on CAR T therapy, genetic therapy, precision medicine, $1 million a year drug to reverse a genetic defect, and all this conversation is, you know, for naught. So we have to be able to be nimble to consolidate and use new technology appropriately. That's where the real challenge is going to be, on the edge of all of this. And we know that a good example, cancer, drugs for rare diseases and so on, they'll break the bank of every one of these organizations if there isn't a scientific basis behind how are we going to allocate these drugs appropriately.
Yeah, and we appreciate that perspective, and just we're going to start wrapping up here, but it is very exciting to see the opportunity that AI is presenting to the world of healthcare. And as an operator, it's very exciting to see companies like Bloom, and thank you for sponsoring this again, Arun, but the opportunities that Bloom and other AI companies are presenting to operators like myself in not just making things more efficient and making, things more possible for better outcomes, but I think this is going to provide an opportunity for companies to now really get to what Dr. Nash was talking about, a true value-based care for the patient, a quality outcome.
And Jared, if I may steal a minute of the time here. So as you know, we've out of Bloom, we've hosted several webinars, but I must say having Dr. Nash on here has really changed the conversation and brought us to what I'll say is the true north for Bloom, which is to make a difference to the patient. And that really needs experts like Dr. Nash and the set of attendees here on the call who understand that this is not a simple problem to solve, and who understand the complexities on the clinical side, because that's when we can embed the technology appropriately. So Dr. Nash, I want to thank you for taking the time and sharing your expertise and bringing your amazing network here to the table with interesting questions and helping with the conversation. I hope to continue this discussion.
Well, thank you. And I'm excited about the capabilities that Bloom and companies like Bloom that are out there, doing the hard work of harnessing this tool to improve health. I mean, I hope I'm around to, see it and potentially benefit from it as a patient. So kudos to you guys. And I would also add back to what you said, Jared, since you brought up our colleague, Tom Lowry, give me 30 seconds of free advertising. If you want to see Tom Lowry in person, come to our 24th annual Population Health Colloquium in Philadelphia on our campus for the first time in 2 decades, May 7, 8, and 9. We're going to tackle all these issues in person, up close and personal. So I invite everybody who's been on the webinar to take a look at the Population Health Colloquium. Hope you'll join us. And thanks again to Bloom for the support. And again, I think this sector is super exciting. And hopefully continue conversations like this to focus on what's the true north. How do we improve health? How do we reduce waste? How do we reduce error? And boy, our country really needs to pay attention to these issues, because all of us together, we're the biggest business in America by a wide margin. And I would argue the most important business too.
And Dr. Nash, we are planning additional webinars on this and other related topics.
Great. Good idea.
For a group of experts to help contribute to that discussion.
Great idea.
Yeah, well, thank you to Arun and Dr. Nash for the wonderful discussion that we've had, and I appreciate you being in attendance. And for those attendees that are still on, please follow their LinkedIns, both at Bloom and Dr. Dave Nash's, who is a big user of LinkedIn, as we've talked about, but please follow them for any future updates. And thank you for attending.
Great. Good job, Jared. Thanks again.
Yep.
Bye.
Bye.